is Dr. David Richard, who is the Deputy Secretary of the Department of Health and Human Services in Raleigh, in charge of behavioral health and developmental disabilities. Dr. Richard, good morning. How are you?
Henry, good morning to you, and I appreciate the doctor title, but that's not correct.
Oh, it's not Dr. Dave Richard, okay? Mr. Dave Richard.
That's
all right,
better.
very good.
Thank
you. Thank you, Mr. Richard. Let's talk about the report that came out yesterday. The governor has made such a big deal out of the cost overruns with Medicaid, saying that it's really affected everything in the state of North Carolina because it's been almost impossible to get the budget director and everybody, the legislature, the governor's office. They can't get their arms around what Medicaid is actually costing the state. And you've heard him say over and over again that there was a $500 million surprise last year after they started planning the budget that kind of threw a kink into everything, including some of the things they wanted to do, like give raises to school teachers and government employees. And so he appointed this 5-person board to work on that and to reform Medicaid. So the essence of that, what is the essence of the reform?
Well, the reform is really based on several factors. One of them is the physical health side of Medicaid, and that's, when you think about your doctor and just essential acute care. And what we have proposed is a plan that uses accountable care organizations, which are organizations that wind up essentially being the place where people will go. You go to a regular doctor, your primary care physician, but these organizations themselves will have incentives to, one, do much better care, coordinate that care for the individual, two, to have cost predictability to save money. And the way we do that is by creating incentives within those accountable care organizations for either, if they save money, to share in that savings, or if they don't, to share in the loss. So it creates the budget predictability we're looking for in a Medicaid program, but aligns the incentives in the right way. We also have a behavioral health side of it that continues to build upon what we have in our LME MCO system, and some work around the long-term care for people who are older.
Is it possible to, predictability is the key, right? I mean, you use that term twice in that description, and that's been the problem. It's a question of how to predict what the state is going to have to spend on Medicaid, and that's the essence of what this reform group is trying to do?
It is, and the way the committee was set up was that the department was charged with the responsibility of pulling together a plan, and I think we've spoken before. We spoke to hundreds, thousands probably, of people across the state to get their input in this process. And what we think we've done is created a plan that, one, builds upon what is working in North Carolina already, the things that we know we do well, adds the element of risk to the provider side, but puts the provider in a position to make decisions. We all want our physician to be the person who makes the decisions about our health care. We'd rather that not be the insurance company. And this is the method that we're choosing to look at in the Medicaid reform. But the element of risk, the sense that these accountable care organizations are accountable for the cost that that the people that come to them are receiving, adds that predictability as we continue down this road.
If you're just joining us, this is Dave Richard, the Deputy Secretary of the Department of Health and Human Services. There were three things that Senator Pate pointed out that he wanted out of this commission that he said he feels this report falls short. Number one was predictability. Number two was to simplify the way Medicaid was administered in North Carolina. And number three, to address more the mental health side of treating patients and looking at the complete health needs of a patient. His comments this morning, Mr. Richard, were that this report falls short of that. It's a good start, but it doesn't go far enough. What's your reaction to Senator Pate's comments there?
Well, first of all, let me say Senator Pate is an outstanding leader in North Carolina, especially around health care and other issues. So we respect the senator's comments and appreciate his taking such a deep look at the plan and the work that he did on the committee. What we tried to do, and this is the most difficult part, is to one, listen to what people said across the state. And what we heard from folks is that yes, we want this concept of predictability. We want to make sure we're saving Medicaid, but you can't disrupt this system so badly that you actually wind up doing the alternative of what you intended, which is to create more chaos in our healthcare system. And we have a lot of chaos in the healthcare system across the state and the country today. So, as Senator Pate described, maybe it doesn't go as far as he perhaps would like, and maybe others, but it goes a lot further than others would have liked to go. It changes the dynamic from a pure fee-for-service system, which we pay providers for volume and not for outcomes, to one in which we change that dynamic to paying providers to the outcomes that they achieve for patients, create an incentive plan for those providers to do it that well, and also penalties on that side. In terms of the whole person approach for behavioral health and in the general acute care side, we believe this model actually brings us closer to that. It isn't the panacea, but there's no place in the country that is doing it perfectly. The ability for the ACOs to connect with our currently existing and more consolidated local management entities across the state will allow for us to, experiment, to test, and hopefully create a system in which both the behavioral health managed care organizations and the ACOs are responsible for that health care. And they'll both have incentives and penalties around their performance measures related to that group of people.
One of the other things that Senator Pate said this morning was that he does not believe that we save enough with this plan, that the plan says that we'd save between 2% and 3% in 5 years, and that in some states we see Medicaid growing at 6% a year. So it's, this plan won't keep up. Is that a concern?
Well, I think it's always a concern about the cost of Medicaid, and there are many factors that go into how Medicaid growth happens. We believe it does two things. One is that it does save a significant amount of money. 2 to 3% in a $13 billion budget is a significant amount of money, and it does create this predictability. What we have known for years is that it's the volatility in Medicaid that's been the biggest problem in terms of creating a budget that makes sense. This puts the incentives in the right place. It actually puts the providers and everyone else on notice that we have to achieve these savings, or there may be other steps that we'll have to take to go forward. But it does create significant cost savings. The other alternative, which would have gone to a full-fledged managed care system, a capitated at-risk system, was something that most people that we spoke to weren't ready to go to. And I believe that was really an important component of what we were trying to achieve, is something that providers could buy into, constituents who must use these services, and frankly, the management structures that would be in place. So we think this causes the least disruption. It absolutely gets us on the right path with cost savings, and frankly, the most important thing, it's best for the patients who receive these services.
The managed care piece of this is something that a lot of people in North Carolina have feared. I take it now, Mr. Richard, that this means there will be no managed care in North Carolina, at least for now.
Right. I think at least for now we're talking about a different model now, and I would say that the ACO model is managed. It isn't the traditional HMO kind of management that you think about. But not managed from outside the state of North Carolina by insurance companies, right? Yes, sir. That's exactly right. Yeah. And I think that was a big fear of a lot of folks. I think it was something that we listened a lot to, and frankly, there are really good companies that can do this work. So it isn't our fear about their ability to do that, but rather the desire to build upon the quality stuff that's happened in North Carolina, like CCNC, the Community Care Network, the LME MCOs as they're growing up, and frankly, to build upon what providers tell us they can do, and I believe we've got a winner.
We've only got about 30 seconds left, but I got to ask you this question. So many people have criticized the governor and the legislature and your department there at HHS for not expanding Medicaid. And the governor has said he's not opposed to expansion of Medicaid, but he can't feel good about even talking about that until we get our arms around it. Is this, for those critics, is this a step closer to expansion of Medicaid, or is that just not in the foreseeable future right now?
I wouldn't think it's in the foreseeable future. Now, clearly the governor is going to make that call along with the legislature. I believe what this allows us to do is to create a Medicaid program that works for the people, for those people that are currently eligible. The decisions about expansion or not to expand will happen down the road, and that'll be at a different level than I'm working at.
All right, and of course now this plan goes to the legislature, so there's going to be some negotiating, right?
I would assume. That's right. Yes,
So would I. All right, thank you, Mr. Richard. Thanks for the time.
Henry, thank you so much.
Nice talking to you.